Before I start, thanks to the organizers for inviting me to speak here today, and thank you to all of the patients with melanoma and their families who came out for this great event. And then also just wanted to say how grateful I am as a radiation oncologist to work with such a great group of colleagues and collaborators who really, give radiation a chance to help patients in the ways that it can. And so in terms of our outline, we're going to talk about radiation therapy as a means of local control, either after lymph node surgery, after surgery with positive margins, for patients with disease in the brain, as well as for patients who need palliation or who have a few number of or oligometastatic disease. And then we're going to talk about two novel areas of radiation therapy, and those are radionuclide therapy to augment immunotherapy, as well as combination immunotherapy with radiation. And so before we get into this too far, we need to talk about what radiation is. And so this is the electromagnetic spectrum. And as radiation oncologists, what we really care about are the things on the right, the ionizing radiation or radiation that can break chemical bonds. And right now, UW, we predominantly use X-rays in treatment of melanoma and all other cancers. Come spring of 2026, we're going to have a proton unit, and that will allow us to do some other new and exciting treatments in this context. And so how does radiation work? Radiation works by breaking double-stranded bonds in DNA. And so when a double-strand break occurs, that correlates with lethality to the cancer cell. And so every gray we give causes about 40 of these double-strand breaks per cell. And again, those cells are what lead to loss of information to the cancer cell, and that ultimately leads to it no longer being able to survive. And a common question we get is, why do we do this over multiple fractions? It's awfully inconvenient. Why do we do it over multiple days? It would be much more convenient to do it one day. And that's true. People have thought of that. The answer is that normal cells can actually repair DNA damage caused by these breaks, and cancer cells are very inefficient at doing this. And so by allowing time, we allow normal cells to repair, and cancer cells can't as well. And then the cancer cells see a high dose, but our normal cells see a dose that they can tolerate. And this was probably best illustrated by sterilizing rams in France. And so they noted that when they sterilized them with a single fraction of radiation, that they got a lot of skin reaction and they had a lot of discomfort. But if they did it over 3 days, the rams were able to be sterilized just as well, but they didn't have any toxicity. And so that principle is essentially why we do it in multiple fractions, and that's probably unfortunately a memorable image. And so in terms of what do we have to use for radiation at UW, we really have the full suite of systems that one might want at a major cancer center. And so we have a Varian TrueBeam is our main workhorse machine. That is able to do most of the treatments we do. The treatments average 15 to 30 minutes on that machine per site. It has imaging built into it, and so we're able to align patients very precisely using that. It also has the ability to gate so that we can treat patients at a breath hold if that is advantageous in terms of positioning the tumor. And we can do radiosurgery on that machine. The other machine that we use quite a bit at UW, and I don't know if this is going to play today here, but we use the ViewRay machine quite often as well. It doesn't look like the video is going to play. That's too bad. But the ViewRay is a MRI-guided machine, and basically the way that works is it allows two things. One, it allows live tracking of the tumor. So when we're actually treating the tumor, we can physically see it. And that allows us to account for if anything else changes, if bowel changes shape, if the stomach empties, if anything like that happens, we can see it and we can adjust the treatment to make sure it's safe. It also allows us to change the treatment each day. And so as you can imagine, people's internal anatomy changes every day. And most radiation plans can't account for that, but ViewRay can. And that's made treatment much safer for tumors that are in really challenging areas. And so we really use our ViewRay machine, our MRI-guided machine, to extend the types of radiation that we can deliver. And it's allowed us to deliver treatments in places where that was previously impossible or very unsafe. And so we'll kind of go through one by one and kind of follow through a survey of ways we use radiation in melanoma. We'll start with lymph node surgery, and then we'll work through positive margins, palliation, and then for patients with metastatic disease. And so radiation for lymph node surgery is sort of where it all started and is probably the best known area of radiation in melanoma. And we've known for decades that radiation can reduce the risk of recurrence in patients with high-risk nodal disease following surgery. This was tested in a randomized trial, and high-risk patients were included. There's various factors that make a patient qualify as high risk. Those include, lymph node number, extranodal extension, the location of the disease, and we combine those all together. And if patients are included, then we can consider radiation. And what they found was radiation decreased the rates of recurrence from 36% to 21% if radiation was given versus if it wasn't. It didn't improve overall survival, and it did cause increased rates of fibrosis and lymphedema. And those are side effects that at this point we have more tools to manage than they did when this trial was done. The other big change that has happened since this trial was done is immunotherapy, and specifically that immunotherapy has moved into the neoadjuvant setting or the pre-surgery setting. And while we don't have a tremendous amount of data yet about what we should do with the different responses we see from immunotherapy prior to surgery, it is a source of increased information. And so we can say, well, you're high risk, but all your lymph nodes basically completely, disappeared with immunotherapy. So probably you don't need radiation. Or, for example, maybe someone's lymph nodes grew during immunotherapy. So immunotherapy is probably not a very effective tool for that patient. Then radiation is even more important. And so I think it's added a lot of information that's helpful. Treatments are typically 5 or 20 treatments. The advantage of 20 treatments is it's slightly, potentially has theoretical, slightly lower risk of long-term side effects than 5 treatments, but there's various reasons we'll use both. And one of the tools we've had more recently that's helped reduce toxicity is IMRT. And so on the bottom right is a modern treatment plan compared to kind of an older school treatment plan on top. And the modern treatment plan allows us to push the radiation dose off the skin. You can see that with those different colored lines represent different doses. And so we're able to bring the high dose off the skin, we're able to keep it out of the lungs, and we're able to keep it out of the esophagus. And so we can move the dose around and reduce toxicity with modern techniques. Another place that we use radiation really commonly, and this is similar to Dr. Newman's case earlier, is we use it following surgical resection. And to her point, it's even more common now to have immunotherapy before that resection. So very multidisciplinary. We know from some phase 2 data and some retrospective data that radiation reduces the recurrence after surgeries where there's tumor on the edge of the specimen, that's called a positive margin, by about half. And one of the things that we really focus on in people in this situation is the individual risks and benefits. And so one really valuable forum for that is our melanoma tumor board. I think we have a really excellent melanoma tumor board at UW where Dr. Ma and Dr. Albertini and Dr. Newman and Dr. Wang and all the other physicians who treat melanoma are there, and we discuss all the cases, and you get a really complete view of the situation in that context. And there's obviously different parts of the body that are easier to radiate or safer to radiate than others. And so we have this individual risk and benefit discussion with patients, and then typically we'll treat these positive margin cases with 5 treatments of radiation. And the case shown below is sort of in comparison to the last case where we're treating a very large area. Here we're treating a very small focused area. This was treated after an adrenal melanoma metastasis was resected. This was treated in 5 treatments to try to sterilize a positive margin. And you can see by the colored lines there, that's where the dose was falling off. We were able to push the dose away from the kidney and the bowel. And we were able to do it in 5 treatments. And it has been so far very effective for this patient. And so this is something we can do also similar to Dr. Newman's case in the back. We can do the same thing in a back as we can do in the abdomen. Another area in melanoma that's really important that radiation has a role is to palliate symptoms. And this is a reason a lot of people, and myself included, got into radiation oncology is because we really enjoy this aspect of our field is to reduce pain and suffering from cancer in situations where other potentially more conventional means aren't effective. And so we know, for example, that radiation reduces the pain from bone metastasis by about 2/3. There's some newer data that radiation can actually prevent fractures in patients with cancer that's spread to the bone. And often we'll use this to prevent progression or reverse progression in critical areas. So in a critical weight-bearing bone, or for example, in the bronchus of a lung, or in this case I'm showing here, this was treated on the ViewRay machine. This was a patient with very large liver metastasis who was having significant pain, and we treated that with several courses of palliative radiation. And we were able to avoid enough of the liver to keep good liver function. And we were able to, if you can see in brown there, the stomach, we were able to also avoid and avoid any significant toxicity to the stomach. And each time we did this, the mass shrunk significantly and pain reduced. This is just an example of one of the things we can do with that ViewRay tool that would be completely impossible otherwise. Another area where where radiation and melanoma have really collided and is really growing is in the oligoprogressive or oligometastatic states. And so what does that mean? And so these are kind of made up radiation oncology words that have spread through a lot of cancer medicine now. But the oligometastatic state was defined as the state between having a lot of metastatic lesions and having localized disease. And some professors in the early 2000s thought that this state has some unique biology, and it's a place where radiation can really intervene. And so in those cases, usually defined as 1 to 5 lesions, you can use radiation to essentially cytoreduce the disease, so to kill 99% of the disease in the body and then leave the rest to immunotherapy potentially. We most oftenly use radiation in the upfront setting when there's a threatening lesion. So we kind of combine the oligometastatic and the palliative in that sense. The other place where it's been really powerful is in oligoprogressive, and what that means is the immunotherapy or the targeted therapy mostly worked, and so it shrunk down 90% of the lesions, and now there's 1 to 5 of them that are still persistent or still growing. And because there isn't an infinite number of lines of therapy, we will often use radiation as a tool to kill those cells that are not responding so that the patient can continue on that line of therapy longer. And that's also been a very effective use of radiation in this setting. We use a technique called SBRT, stereotactic body radiation therapy. All that means is we use high doses of radiation with high precision. And so we're using molds for the body. We're using techniques with radiation that are inhomogeneous so that the dose falls off really quick and that the dose of radiation has a relatively low impact on the surrounding structures, or as low as possible. And in the case example at right, this was a patient with melanoma who'd been on BRAF/MEK inhibitor for about a year, and there was a spot in the lung that had grown over several serial images. And so we decided to ablate that with radiation. And so we did that with 5 treatments over the course of 9 days. And so far that lesion has been well controlled. And we expect with a lung lesion like this, we expect control rates on the order of 80 to 90% from radiation, and ideally closer to 90%. And then finally, the other place that that conventional radiation is really useful is in progressive CNS disease or disease in the brain. And this is where we use radiosurgery. And this is actually not a surgery at all. It's just a high dose radiation, again, delivered very precisely with high gradients. And so the goal here is to treat the metastases in the brain to a very high dose while sparing as much brain as possible. And we do that with arcs of radiation. Our current technique, it takes about 30 minutes for the first lesion to be treated and then about 15 minutes for each additional lesion. By the end of 2025, we think we'll be somewhere in the range of 10 to 20 lesions per hour. So we're looking to dramatically increase our throughput, and melanoma patients are one of the main drivers of our need to do that as a cancer center. And again, here we have an up to 90% local control rate. Some cases will need surgery because the lesion's either too large or it's symptomatic, and radiation does not resolve symptomatic lesions very quickly, which is one of its weaknesses here. There's also a risk of necrosis when combined with immunotherapy, and that's something we deal with a lot in melanoma. And one tool we have that's new for that is the fluciclovine PET scan. That's available now on trial at UW. But that's been a very useful tool to help us decide, is something that's changing in the brain necrosis or is it progression? And so that's another new tool that we have. And then typically we do surveillance every 3 to 6 months because, again, we want to catch these lesions when they're small so we can do this very focal radiation technique and minimize side effects. Moving on to some novel therapies. This is from the Morris lab. Zach Morris is the other physician that treats melanoma predominantly in the radiation oncology department. He's since become chairman, and so is treating a little bit less melanoma, but is still active in this area, especially on the research side. And so radionuclide therapy is a new area, is in a new area of medicine called theranostics. And this is combining therapeutic and diagnostic agents. And these drugs have two components. They have a drug component that targets whatever cancer cell you're trying for, in this case, melanoma. And then it has a radionuclide, which is a radioactive particle that is sort of the business end of the drug that does the killing of the cancer cells. And as you can imagine, there are dozens of different radionuclides that all have different effects and half-lives and things that we can use in treatment of melanoma. And right here, you see a preclinical study of a drug that's in a different clinical trial than what I'm going to talk about today. So I apologize, it's a little confusing, but this was a mouse that was treated with a radionuclide, and you can see that in figure A, it accumulates in the tumor, the drug does. And then in figure H, you can see that these mice that were treated with a combination of immunotherapy and the radionuclide had the lowest level of tumor volume at the end of the 30-day experimental period. In terms of using this now in the clinic, we have an open clinical trial using a drug called VT101. It's a lead radionuclide, which is an alpha emitter. And alpha emitters are really interesting because they are both very potent forms of radiation and because they're very short acting. And this is targeted to the melanocortin receptor. And this radiation, again, is over a couple cell lengths. And the hypothesis here is that, similar to a tumor vaccine, the radiation plus the immunotherapy will hopefully help generate a stronger immune response than either one alone. And currently we are enrolling stage 3 and stage 4 patients to get this combination therapy at UW. And again, a really unique opportunity. And then the second clinical trial I wanted to talk about with my remaining time is an injectable immunotherapy combination. And again, this is on the same sort of concept of using radiation as a tool to augment the immune response. We think radiation can do that through killing of tumor cells, which releases antigens, and then we can add to that as well with injectables. And so this injectable that we've acquired is the Army liposomal formulation Q. And so this comes from the U.S. Army. Zach Morris, in addition to running a tremendously successful immunotherapy lab, is also a officer in the Air Force Reserve. And so he met some people at Walter Reed, and they got to talking about immunotherapy, and they talked about this drug. And what it is a vaccine adjuvant that was used in HIV vaccine development. And so basically it makes the T cells more activated to an antigen. And so this is going to open this fall, and it is going to be a study for all skin cancers, not just melanoma. Patients who've been on melanoma or been on immunotherapy for 12 weeks with progression, and then are appropriate to continue with immunotherapy. So they don't have, side effects that would preclude that. And so after enrollment on study, patients will get radiation, again, to try to increase the antigens that are present. We're going to then inject the tumors to further augment the immune system and immune response, and then they will get their immunotherapy the following day. And then that can be repeated up to 2 more times. So a total of 3 times we can give this cycle of therapy. And our hope is that this is going to improve response rates for patients who are not responding to immunotherapy. And we know that the rates of response in that group is about 5%. And so we're hoping to get that up considerably higher with this combination therapy. And so with that, radiation is a versatile tool that we believe we can help a lot of patients with melanoma. And we're very grateful we're at a cancer center where radiation is used as a common tool in this disease. In its current state, it's very valuable in local control, and I hopefully showed you that. And then we have clinical trials in development to use this as a systemic agent as well. And we think the future is very bright there. So thank you very much and look forward to questions.